really excited that you've decided to join us today. At Orem, we take a lot of pride in being at the forefront of new technologies. And this technology is not just technology for being new, it's something that's going to really help drive your business, bring in new streams of revenue, and really make it easier on both yourself and your patients. Today, we're going to be talking about our Simplus 3D denture system, and we're extremely happy to have Dr. Chris Bertsch join us today to speak on his experience with it. He's implemented the Simplus system to great success, and we're happy to have him join us. He was born and raised in Saskatoon, and he enjoyed his time at the University of Saskatchewan while completing his degrees in physiology, finance, and dentistry. While there, he was a representative, the social representative, and was an active member on the student council. He was also a founding member of the first student-run dental clinic in Saskatoon, Direct Dental. He enjoys practicing in all areas of general dentistry and strives to make his patients feel comfortable and taken care of. Takes particular interest in using dentures to restore the function and aesthetics to his patients' smiles. And with all of that, he's also got a great haircut that I can really appreciate. So we'll turn it over to Dr. Bertsch and let him roll with it here.
My barber appointments are my most committed relationship.
Yeah, I hear you.
Thank you everyone for joining. So yeah, thank you so much for the introduction, Daniel. We're talking about the Simplus denture system. So I'll just start with a few pictures. So there's a picture of me and my wife on holidays in Victoria, me finally graduating after 11 years of university. The "Hey, look, Mom, I made it" scene. I enjoy, my favorite activity is hanging out with friends, going for brunch, and horseback riding. So huge thank you to Orem for allowing me this opportunity. I always wanted to teach, and the thought of going back to the dental college is a little bit too much. So this is a great platform for me, and I'm super passionate about dentures. So thank you. A couple things. I only work with Orem, so I only know what they offer. And I've only ever used the iTero scanner. That's what we have at both clinics right now. I'm in Kindersley and Rosetown, Saskatchewan, two small town practices. So the webinar series for the spring, today we have the blueprint for dentures. My kind of whole vision for the whole webinars is that today will be like an overview of everything, and then we're going to have more in-depth ones. Just because I realize that some people have never done dentures, some people do dentures, some people were never taught dentures in dental school. I was told that like 40% of dental schools in America don't teach dentures anymore. So I feel like I want to be able to help people who are starting out and people who are already doing dentures the traditional way and transitioning to digital. So that's my goal with the webinar series. We'll see how I make out. So overview for today. So we're going to talk about the Simplus system, tips for incorporating dentures. I've worked at 4 clinics now, and every time I go to a new clinic, I implement a denture program, I guess. Start offering dentures. So I've had to do it 4 times. So I just thought back to what I do and how I did it and share those tips with you guys. The ideal Simplus patient, advantages of digital dentures, tips for scanning, the lab script delivery in cases. So let's see how I make out. So this is a traditional workflow. This is how I started. So when I started doing dentures, when I graduated in 2019, I was at a brand new clinic in Prince Albert. It was really slow. And so I was like, hey, I need to offer dentures, or I don't know, find another job. And so that's what I did. This is how I used to do it: custom tray, Alginets, PVS, wax rims, all these appointments. I used to have 7 appointments I would do. And now I'm down to 2, and it's incredibly more efficient. So I really don't want to dwell on traditional denture workflow, but I just want to show it in juxtaposition to the Simplus denture system, which is way more efficient. 1 appointment to get all the records, and then you have your delivery. So way better for the patient, way better for you as a provider, less chair time, way more efficient. So we'll go over that. So simplest dentures, to define it, I always have this picture and it's complete dentures, but the simplest denture is any denture, digital denture done by Orem. So completes, partials, immediates, and it's all encompassing term. It's just their digital dentures. So so this is my process. So right now, just to kind of show you where I'm at, I showed you where I started with the traditional workflow. And now when I book a patient, we get a call for a denture. We start with the consult, sorry. So we do the consult, we take pictures, we book 30 minutes for that appointment, take all the records, and then at the delivery, we book another 30 minutes. At the consult and scan, I always take a deposit. I started doing things as I got burned. So I take a deposit, and that's to cover the lab bill. If a patient changes their mind, if something happens, they don't want their denture, they can't have it, anything. The lab bill's covered because they have committed to it at that appointment. And then delivery. So roughly, cost for a set of dentures, upper and lower, is just over $2,200, and a total of 1 hour chair time. So and I'll go through my delivery process. It's rare that we have a patient come back with needing adjustments, but there would be that additional appointment. We book a little 15-minute slot, they walk in, we adjust it. It's not that big of a deal. So overall, I would say an hour, and even delivery doesn't take 30 minutes. So same thing with partials, might have to adjust the teeth. I do guide planes, rest seats, that type of thing. So that is done in 30 minutes, and then delivery. So $2,600. And how I look at it with Simplest, because I also do Invisalign, is Simplest is the Invisalign for ortho. I think I said that right. Simplest is the dentures, what Invisalign is to ortho. It just makes it easy, it streamlines it, makes it accessible for new providers to use, and takes all that muck and guck out that they teach us in dental school that you're just like burdened with. So that's completes, partials. My immediate process, it looks more complicated, but it's really not. We do the consult, I do the posterior extractions, starting with molars, second premolars, enough teeth, remain enough teeth to maintain a stable bite. And then we do 6 weeks of healing. And then we scan for the photos, or after that 6 weeks, we get them in, we do a scan, we take pictures. I have all this in more detail coming up. And then we do the delivery and any follow-ups. I do a 24-hour recall, because when the patient gets their denture, they're frozen, they just had all their teeth out, you just shoved a hockey puck in their mouth and they want to get out of there. So we do a 24-hour recall, and then a 1-week recall, and a 3-month recall. So something that I cannot stress enough with immediate dentures, and something I've had to learn, is to preserve the buccal bone as much as possible. More buccal bone is going to really affect the fit of the denture and have more surface area, more retention for the patient. So getting good at extractions. I'll direct you to my mentor for extractions, Dr. Neki Jamal. He offers a course, the Ultimate Third Molar Extraction course. It's incredible. Its focus is on like wisdom teeth, but I learned so much about surgically removing teeth that I encourage anybody who's not comfortable with extractions or is thinking about getting into immediate dentures to look into this course, because getting good at extractions is really going to help your results with the immediate dentures. So shout out to him. So incorporating dentures. The first educations, like I said, some people have, some people don't. I'm hoping to provide everybody with some education over the course, over the webinars. I'm going to look for sources and textbooks and different things to help supplement, but for right now, it's pretty much experience-based. And this is a presentation on how I do it and what I do. And it's based off of 5 years of practice and being burnt and learning and succeeding and all the above. So Beyond that, I'd say practice scanning dentures, scanning edentulous ridges. When I first started, it took me 45 minutes to scan a denture. So it set me back 45 minutes because I didn't expect it to be that long. So being prepared and scanning, because it can be frustrating at first, is really important. Now I'm at the point where the assistants all do the scanning. They scan the denture, they scan the patient. So it really frees up a chair for me. So case selection, important, like figuring out your patient's personality in like 5 minutes or less. I'll give you guys some points and tips on what I've learned, but that's really important. And then the biggest thing, thinking back, is just starting the conversation, just having the conversation with people has led me to being successful with dentures. People come in without teeth, missing teeth, you need to pull some teeth. They already have dentures. It's all just a platform to start talking about where they're at. And then finally, treatment and delivery. So that's my goal, is that people will be doing dentures after this. So incorporating dentures, so the case selection. So my recommendation would be starting with patients with dentures. So from my experience, when patients come in with dentures, they love the fit of their denture, but the teeth are worn out. It's been several years, they can't chew like they used to. Oftentimes patients, I talk about having a spare denture if they ever need to lose theirs, break it, anything like that. It's your teeth. You want to have a backup. You want to be able to function still, or if it breaks, you don't want to have to go without. So I have these conversations with patients. I always talk to patients about when they come in and their denture is loose and they want to reline. I do relines, but I do it with the Simplest system now. I don't do the traditional reline where I send the denture in with the PVS. Being in a rural community, it's a 1 week turnaround roughly. So I usually get them in Monday morning. They have to come back Friday, so they've been without their teeth for that long. So integrating Simplest into my practice, I don't need to do that anymore. I do the reline impression, scan the denture, send it off. The patient goes out with their denture, and a week later they'll have a brand new one that fits better. So, and then patients who are happy with the fit but not the aesthetics. One of my favorite patients, she told me she looked like Carol Burnett. I didn't know what Carol Burnett was, so I had to Google that. But so people sometimes will get dentures made they're not happy with, and they don't want to go back to where they had it because they weren't happy to begin with. So just asking them, do you like the look of it? Are you happy with your smile? And then people will let you know. So kind of some talking points there with people with dentures already. The biggest thing, I should put this in bold, the biggest thing I've learned with dentures is don't reinvent the denture. When I first started and I was doing that traditional workflow, I was starting with the alginate, the PVS, and I would try and get the patient in the perfect CR and get all the phonetics and everything different. And in the end, you're giving them a brand new denture, but we all are creatures of habit. And what I've learned is that people don't want a brand new denture. They want their old denture with new teeth or with a reline. They want it as seamless of a transition as possible, so that when you put the new denture in, it feels like the old denture, but better. And so that's what I found the biggest success with Simplest. And I can't stress that enough. Don't try and reinvent the denture. Figure out what the patient doesn't like about it. If it's the reline, needs new teeth, the aesthetics of it, and then focus on that. Because otherwise you're just going to be creating yourself such a problem. And then personalities to look for. I'm partial to the old ladies because I always have been, but the elderly old women often have had dentures forever. They're very aware of what they have. If they have very little ridge, if they know it's not going to be retentive. So they also have time. They love coming into the appointments. They are easy to work with. So that's kind of who I start with. But definitely people who are laid back, easygoing, people who wear their dentures. I can't stress that enough. So many people keep them in their pockets, take them out to try and eat, that type of thing. Trying to get those people in a new denture is going to be a challenge. So start with the easygoing people who are happy with their dentures and go from there. So some red flags. I've had several times now, well, no, 3 maybe, where I've had to repo people's dentures because they weren't happy and I was tired of the appointments and it was just not going anywhere. So give them their money back, repo the denture. So I've come up with this list based off of that experience. So again, patients whose dentures live in their pockets, people who have dentures but they don't wear them. It was crazy. I had this one old man come in and he hasn't had teeth for 10 years and he wanted dentures and he had steak the night before. And I was like, I just don't know. Like, I mean, it wasn't on my radar that day to take on that challenge. So I was like, you know what, you're functioning, you're fine. So. And people with no ridge and a flat palate. So those ones are going to be very difficult to try and get good retention without implants or adhesive. And I always have those conversations with patients, explaining to them, and that's a good thing with the scan too, is take a scan of their arch, of their teeth, what they have working with, and then you can show it and explain it to them and show them their flat palate, show them that they don't have much for retention. The more surface area, the more retention, the better the denture is going to be. So if a patient doesn't have those, it's just you're working with what you got and helping them understand that goes a long way. So those are my red flags I've come up with. So this is where we're starting the conversation. So I always take advantage of spec exams. Those are like my bread and butter because the patient comes in, they need a tooth pulled, and then you look, you take the x-ray, there's periodontal disease, there's bone loss, or there's decay, other teeth missing, whatever it may be. It's the perfect segue into talking about replacing the missing teeth. It's what's best for them, and it's offering them a bigger solution instead of just dealing with that one problem they came in with. And so I just kind of talked to them about their options and what that would look like. And so immediate dentures, they're my favorite. I'll say this many times. Anytime a patient comes in, periodontal disease, that type of thing, we always take a pan, go into discussing the bone loss, the effects on that, the health of the patient, and why they benefit from dentures, existing dentures, if they're happy with it, if they have a spare. I do this at checkups too. The denture is often sitting on the hygienist's table. So I'll pick it up, I'll look at it, I'll ask the patient what they think of it. I'll comment if the teeth are worn, if there's a crack in it, anything like that. I'll ask them if they knew about it, and then I'll again go into further detail if necessary. Partials are also amazing. We won't really talk about them today, but we will. They're so easy to do with scanning. You just scan the arch, send it off. So if a patient's missing multiple teeth, they've never had a denture before, I always tell them chewing and having teeth to chew with is the spice of life. Variety is the spice of life, and having teeth to chew is. So talk about those with them and just taking every opportunity I can to incorporate dentures into the practice. Another heavy hitter, in my opinion, is setting expectations. I cannot stress enough to patients, when I first started doing dentures, I was like, they're going to be amazing. You're going to love them. They're going to be your brand new teeth. I would just like try and create this amazing experience for them. And then I realized it's like, at the end of the day, you're giving them a prosthetic. You're not giving them their teeth back, and they need to understand that. So I always use this analogy. I'm always like, imagine I cut your hand off and gave you a fake hand, a prosthetic hand. You need to learn how to write again, how to use instruments again, everything. So understanding that getting dentures is similar to that has really helped me and helped manage those patient expectations, because when you first start the conversation, setting that groundwork for the expectations is so important. Especially like when it comes to, we'll start with complete. So lower always notorious for being a poor fitting denture without implants. So if the patient doesn't have much of a ridge, their previous denture floated, I'll always tell them, well, we'll do the reline, we'll get it tighter to fit. And I always say that they'll still need adhesive, but they'll need less of it. or we can look at implants. And I was going to bring my implant thing, but I have an implant model, and it's implant that supported denture, and I hold the denture and I go like this, and I'm like, it's not coming off. So this is what your implant supported denture would be like, and this is the difference versus what you have. Again, can't stress enough, but talking about the palate, the ridge, that type of thing. With partial dentures, again, I always explain that we're replacing the missing teeth, but we're also going to be, there's a maintenance that comes with them. I go through, if a patient has restorations done, crowns, bridges, fillings, that type of thing, I'll explain to them these areas are susceptible to decay. We need to take care of this. You're going to have to increase your hygiene potentially, make sure you're not wearing it at night. I always go over warranty too with them, so they understand what, in this case, Orum's warranty is and what it covers. Because patients will bring them back and expect warranty sometimes, and it's like, nope, that's not covered. We explain that. And all the while, the assistant's making really good notes about all this happening, or you are after, but I am fortunate enough to have the assistants do it. So documenting all these conversations, super important. So setting expectations with immediates, so important. Because I had a patient come in today, she wants me to pull all her teeth and give her dentures because she's tired of coming for cleanings. And it was like an hour conversation. It was like trying to convey to her that she's not getting a new set of teeth that are going to be better. It was mind blowing to me. I had to leave the room to like figure out where I was. But yeah, again, I say these to the patients. This is kind of my script. I feel like a broken record some days, but repetition is key, and even the assistants start using this jargon as well. So it's really important, actually. So this is my one slide that I kind of hang my hat on because it's references a study, and after 11 years of university, I feel like you need that to be legit. So this is the one study I could find that I didn't have to pay for. So it's done in 2018, and the benefits of digital dentures. So I can attest to all of these. Reduced number of appointments, so important. Like, I work in a rural community, as I mentioned, so patients drive sometimes up to 2.5 hours to come and see me. So if they had to do that 7 times to get a denture, you think they're coming? Like, absolutely not. So for them to come, get all the records done at once, and then the next appointment come back and get their denture is mind blowing to them. Especially if they've had dentures before and they know the traditional process, coming in and having this all done and scanned and not having the gook in their mouth, as they say, they're really, really quite pleased. So the other one benefit that I don't think about because I haven't had to use it yet, but the electronic archiving of the clinical data is amazing. So I have a lot of patients who are in nursing homes and their family needs to drive them, or they need to arrange transportation. So having that digital stored copy of their denture is amazing. You can just send it to the lab, email the lab, get them to remake another denture. The patient doesn't even need to come in. They get a brand new denture, fits the exact same, and they're ready to go. So versus starting over from scratch. So the other thing, and this will be more evident in further slides, is that the digital removing of reline material. I found when I did traditional relines, you'd get that extra bulk from the material, from the reline when it was processed. So having it digitally removed and the denture just comes back so much sleeker and slender. You don't have that issue where the patient opens their mouth right away and the denture pops out, or they're moving their mouth and the denture pops out because it's that much bulkier. So I absolutely love how lightweight they are and sleek. I'm jet lagged and getting over manifold, so bear with me. Also, thank you everybody for the delay. Our flights were delayed coming home from holidays last week, so Thank you for rescheduling. I forgot to say that right away. So tips for scanning dentures. So now we're going to start getting into the denture process. We'll talk about cases, that type of thing. So tips for scanning dentures. Starting with a complete denture is you're going to remove it from the patient's mouth after you're done the reline impression. And sometimes I don't do a reline impression, like if it's just to get new teeth set in the denture, then you don't need a reline. If the denture is retentive, and then I just leave it. But so remove it from the patient's mouth. So important, make sure it's really, really dry. I dry it with paper towel and then air dry it. And then when you start scanning, and then there's a video coming up. So just it's so important to scan in a continuous motion. If you're scanning and holding it in one place for too long, it's taking too many images and it can't like digest it all. So then it starts glitching out. It's really slow. And then it just becomes really frustrating. So the smoother motion you can go and continuing to scan, the better, and capturing a few planes of motion. I should have had some demo stuff pulled up, but anyways, when you're scanning the denture, don't just scan the occlusal, scan the occlusal, the buccal, the lingual, and then wrap around the flange and wrap around the flange to kind of just get all of that. So that it's when you go to do another area, because you want to capture the 360-degree image of the denture, it's all being captured and you're not doing it one plane, another plane, another plane. So that's something I had to learn. And something that happened today actually is that when you put the scanner sleeve on, make sure it's clean. The one that the assistant was using was fogged up, so it was glitching and she was having so many issues. And then I went and looked, and yeah, so we just put a new scanner sleeve on, it was fine. So in the little corner of the iTero, just make sure it's nice and clean when you go to scan them. That was something I learned today. So and the other thing too is if the scan isn't perfect, don't stress too much. Ensure that it's all stitched together and that you can see that it's a denture. I have a good example coming up about this, but there's some areas like the incisive papilla where that is on the denture. It's very difficult to get just because of the flanges coming up and everything. So oftentimes the incisive papilla I just leave, and then at delivery I just make sure it's good and doesn't need any adjustments. So oh no, the scan. Oh, here we go. So this is my assistant scanning. So oh yeah, the disable AI cleanup. How did I forget that? That's the most important. They're all really important, but that's really important because otherwise iTero is going to try and clean up the image and not scan the flanges. So you really want to have that disable AI cleanup. So in this case, it was a implant supported denture, and I have this case later on that I can show you too. But so yeah, scanning in that continuous motion. This video is sped up, but I think we're down to like 2 or 3 minutes to scan a denture now. So it's like it's our great achievement. The girls are leaving for the day. So the lab script. So once you got the denture scan, the lab script on the iTero. So just be clear what you want. So this goes back to me talking about the patient expectations and what they want. Like if they want new teeth, if they want the reline, if they want the aesthetics changed, and if they want whiter teeth, anything like that, put in the shade, make sure you put in. I usually like a smooth transition from denture to denture or from natural teeth to denture, and I get the lab to copy the size and shape of their existing teeth. Sometimes I'll go bigger, but and then the other thing too is when the teeth are worn out, obviously their vertical's closed, so you need to open them up a little bit more space for those new teeth. So I will ask, generally I'll ask for 2 millimeters increase for the height of the teeth and get the lab to do that. So all the stuff that you used to do and they teach in dental school to do with wax and build it up and the putty and all this stuff, I just write it and I put it in the lab script and it happens and it's amazing. So the try-in. So as you saw from how I structure my appointments, I don't do a try-in anymore. I did at the very beginning, and I take it as a testament to how successful this Simplest is I don't do try-ins anymore. I go straight to production. Partials, I can't, like, maybe the odd one. Actually, one the other day I just sent back to the teeth, but the results are so predictable and efficient, and the words are escaping me, again, jet lag, but they're predictable. You know you're going to get a good result. And the other thing is the try-in is monolithic, so it's all white, so you can't tell the shade if it's any different than like if you went with a different shade than like PW1, I think is what it is. It's so bright. So anyways, I don't do a try-in, but a try-in would be a good idea if you're just getting started with dentures, something that you're new to, just making sure the patient's happy with it. Oh, and the other time I do a try-in is if I have a patient that I'm not sure that I want to do a denture for, so they have a few of the red flags. I'm just, my gut's like, don't proceed. But my head's like, yeah, let's do this. Anyways, I'll get a try-in and I'll let them take it for a week and be like, this is what your new denture will be like because of this, this, and this. Often reasons with no ridge, flat palate, that type of thing. So let them try it, and if they're happy with it, I get it made. If not, we just charge for the lab bill. So and then delivery takes 1 week for completes and 2 weeks for cast partials, and that's just for the framework, takes extra time. So this is, I call it my product placement slide, because this is like, we have tubs made with denture adjustment stuff, and this is my go-to PIP paste. I could eat it. We buy it in the big tubs because I use it on every denture. Every time a patient comes in with a sore spot, their denture is not fitting right, I use PIP paste. Every delivery, before we deliver or let the patient go, I check it with PIP paste, because even though it might feel good right away, there can be an area that's going to be rubbing, that's burnt through. I adjust that, check with PIP paste again, and then let the patient go, just so that we don't have, and that's how I cut back on adjustments and then needing to come back, is just check with PIP before they leave at every delivery, and then we're good to go. Tray adhesive, use it for PBS impressions. The applicator stick, I'll show you later. I use them for immediate dentures, and then the yellow sticks in the back for border molding and building up dentures anywhere that it's lacking to get better retention. So I touched on this delivery appointment. I used to let the assistant go, give it to the patient, and then let the patient sit with the new denture for a little bit, and then I'd go in the room, and I'd almost always walk into a fight because they were like, it doesn't feel right, this spot's sore, this spot's sore. So now what I do is I go in right away, check with PIP paste, check the fit of the denture, do the border molding movements, make sure I'm happy with the denture, and then before I even ask them, I make sure I do all this, check the aesthetics, get them to talk, get them to smile, look in the mirror, that type of thing, and then I ask them what they think of the denture. Same thing with partials. I put it in, I check it, use PIP, tighten the clasp, and then I ask them. And then at that point, it's crazy the difference with how I've changed the structure of the appointment. Because now when I've gone in and done all this and then asked them, they're like, oh yeah, that feels good. Whereas before, like I said, you walk into a fight because one sore spot and they're pissed off because they don't have their new denture that's perfect. So. I'm just open the Q&A now. It's in my way. I can't see. Oh, perfect. So delivery appointments for immediate dentures. So the 24-hour recall, like I said, that first appointment delivery, extract the teeth, place the denture, send the patient home. We have a list, a take-home sheet with instructions, which I will be providing at the next webinar because it's all about patient expectations. So 24 hours later, I always tell them I'm going to place the denture and I'm going to be the first person to take it out. So that's how it goes. I take the denture out, I check it, I see how they're going. The number 2 areas that I always see, especially on the top, canine areas and right at the frenum. So always make sure that that's because the patient will complain, they'll be like, it hurts all up in here, all here. And it's like, no, it's 2 spots, but you feel it everywhere because the whole thing probably hurts. So yeah, that's 24-hour recall, 1 week. Depending on the socket healing, I do a PIP paste and check with that. And then at that 24-hour appointment, we book a 3-month recall. When I first started, again, something I learned through the fire is that I would say in 3 months, give us a call and book back for that reline. I'd see them a year later bitching about how shitty their denture is. And it's like, I told you to come back for a reline, and they have no memory. So now the 24-hour recall, we book that 3-month reline, and that's when we do that simplest denture system and get them their new denture. Okay, so now we're going to talk about some cases to highlight all this. So we'll start with completes. So this is like my favorite case to talk about because I was at home sick. And the didn't cancel my day. Had this patient come in. The other dentist over doesn't do dentures. But anyways, patient comes in, 97-year-old, in a wheelchair. His daughter had to bring him in, took a day off work, blah, blah, blah. And he wanted a new denture and a lower immediate because his teeth were bothering him and bombed out. So the assistant calls me, and with my dying breath, I explain how to do this over the phone to her. And they're really good at scanning because we do a lot of Invisalign, but had never scanned dentures before. So I explained to her over the phone what to do. And this is what she does. So on the top here, and this is going back to where I was talking about missing data and not all being stitched together. So at the top, you can see the area that's missing right at the anterior of the denture. So that is what we scanned. Oh, it's in white. You can't see it. Sorry. And then the bottom one is what iTero sends to the lab. So iTero is able to fill that in for a complete denture. So that is where I'm like, if you're missing that, if that's what your scan looks like, stop stressing about it, send it. And like I've had massive success, and I feel like you will too. So this is the dentures here. So obviously the clean one's a brand new one, and the other one's his old one. I never adjusted this once. I didn't touch this denture. He was in and out for the bottom, of course, being an immediate, but the top one we never had to adjust. So I just am so proud of this case because I had nothing to do with it other than explain to the assistant how to use the simplest system to create a new denture so this patient didn't have to come back on a day when I was in. So, and again, this one, she didn't do a reline, just scan the denture as is for new teeth. So it could articulate really well with the bottom. This is wild because last time I gave this talk, I was at 32 minutes and now I'm rushing to get through it all. Completes with a reline. So I'll let you watch this video. This is my assistant filling the tray with the light body PBS. And so I've been drying the patient's tissues, drying in the vestibule. I take the gauze, dry everything. And then and she's doing this. We've already applied the denture or the tray adhesive to that tray before she applies the PBS. So this is me having placed the denture in the patient's mouth and then doing the border molding movement. So pulling up and over, up and over, up and over, and really focusing on the frenums, pulling down. So, and I always hold my finger in the middle on the palate there to try and help stabilize the denture. Oh, and the other thing too, when you first put it in, there's going to be a bunch of PBS going down their throat. So I take a mirror and I just clean that out, pulling straight so it doesn't distort in the denture or the PBS. And then I just trim excess material off, so that it's not a bunch of extra stuff to scan for the denture. So I just use a scalpel and peel that all off and scan. So this is what it looks like. This has got a little bit of burn through on the side there, but I wasn't about to redo it all. So I want a really nice roll over the flange. This one, the denture was a little short, so we built it up with some border molding material. That's that yellow tube stuff I showed in the product placement slide. And then this is after the reline. So this is ready to scan. So, and this is what it looks like scanned. So again, this is where you can see that that bulk of material is all going to be removed digitally. So, and there you can see the incisive papilla. Sorry, this is pre-recorded by a friend because I don't know how to record videos online. But if you look, the incisive papilla hasn't been captured, and it wasn't an issue. So, and then this is his simplest denture. So this is actually one of my assistant's dad's. And I've never seen him since the delivery. She ended up taking it to Saskatoon for him because it's hard for him to get out to Rosetown. And according to her, it's fine. He's happy with it. He's wearing it. He loves it. So again, I haven't heard from him since and adjusted it. So I'm showing you the best cases, obviously. Immediates. This walked in the door the other day and I couldn't be happier. Oops. So this is his pan. So this is where setting expectations is so important because there's no bone. There's nothing to even hold those teeth in. So he cannot go into this process expecting that a denture is going to be good and that it's going to be a nice fit for him. So I stress that it will be a hot dog down a hallway, and that's the clinical term because it's exactly what it's going to be. And especially with the bone loss for that 4-6, I was like, this is just brutal. But at the end of the day, he needs a denture. He needs to get those teeth out. So it's like a rock in a hard place. And I always say, once you're done, we can look. I don't do implants, place implants. So I always refer to oral surgery. So we can consult with them, do that. But yeah, he needs to go into this process understanding that it's not going to be a good fit. So as far as treatment planning for this case, I'll actually go back to the pan. I extract all the molars. So I would leave him with just the premolars and anteriors, extract all the molars, let that heal for 6 weeks, and then take all the records for the immediate. So this is the pictures I take. So at the very beginning, I commented at my consult, I take photos, and I started doing that because the result is just incredible. It's so much better. I had a denture where the last one where I didn't send pictures, the patient ended up looking like a horse. So I had to adjust and pivot and get that fixed. But now that I send pictures, and this is the 4 that I send, well, I don't normally send one with their mouth closed. I don't know why that one made it there. But anyways, I send the smiling and I send these 2 pictures to the lab. And it really gives them a reference and helps them understand who these dentures are for. And it's insane, like how beautiful they are after. So that's the pictures I take. This guy's just starting his journey, so I'm going to include him in the webinars going forward. So come the fall, then I think he will be done with his final denture. So this is a different patient, and this is what the immediate denture scans look like. So we've captured all the palate, we've captured the vestibule on the top and bottom. And this is where it's really important to have that disable AI cleanup and to make sure the tissues are really dry to capture everything, capture the tuberosities, retromolar pads as best you can. Sometimes it's difficult with the wand, but that's what the scans look like when I send them to or I'm requesting a immediate denture. And then at delivery, so I'll talk about extractions a little bit too, because I've learned so much from Dr. Nikki Jamal. And it's really been a game changer for me. So when I extract at the delivery appointment, I elevate usually I leave 4 to 4. So I elevate the 4 3s and 2s. I remove the 4s and 2s, and then I just rotate the 3s out, assuming there's enough to grab. And again, that's to preserve the buccal bone as much as possible. And then once I deliver, I take my hands and I just compress the bone everywhere I extracted, because there's obviously been some expansion. So the denture could rub, it could be an issue. So I just go and I gently compress the bone and then place the denture. So this is the 24-hour follow-up. So this is what most common area, like I said, in the canine area. So that's the indelible marker. Those are those sticks. I've marked the tissues there. And then it shows up on the denture, and I adjust the denture. Oftentimes sore spots on the lingual where the molars are really common on the bottom. Bone chips in the front. I always warn patients, you're always going to get a bone chip there. This is my favorite PIP paste. As I said, this is what it looks like on a denture. And then this is me checking a patient, immediate denture. And again, every appointment, I stress to them how they're going to heal, the gums are going to shrink, the denture is not going to shrink, there's going to be an air space, and it's going to need to be relined. So this is what PIP paste looks like when it's been burnt through. So I adjust every single one of those areas, and I adjust it until the patient tells me that it's good. It's so obvious. You place the denture and I'm like, no, it's still a little bit. You place it. Oh my God, that feels so much better. So it's like, okay, we're done. That's all I needed. So, oh yeah, I used to do temporary relines like Linol at different stages through the healing, but I had so many issues because patients wouldn't keep it moist. They would just get gross with food. And so now what I do is I just tell them to go buy Poligrip and use that. And they complain about how much they have to use and all that, but constantly reminding them that that's what they're going to need to do, I don't really have an issue with it, to be honest. And then, like I said, we have them booked for that 3-month follow-up, and 3 months comes so fast. It's crazy. I'm like, I can't believe it's already that time. So this is a before and after. So this just kind of shows how awesome sending pictures is and how awesome Orem is to toot their horn. At like, it's just so seamless to me going from your teeth to dentures. And that's what I strive for, so that patients don't have people going like, oh, nice chiclets, you know? So this is really, I did this case before I knew I was doing webinars or even had it on my radar. So I don't have much information, pictures, anything like that, but it's just to show you how versatile that you can even do implant supported dentures with the simplest system. So this is the scan, and this is the scan that my assistant was doing in the demo. So this is her existing one. You can see it has the copings in it as already. So oh yeah, this is so with lower dentures especially, make sure, because when you do immediates or any type, immediates especially, because there's that guesswork that goes into it where the teeth are still in place and the lab has to guess where the teeth are going to be when they come out, then sometimes the teeth are set in front of the ridge in this case, like how we have with this lady. So she came in, she had these 2 implants placed, thought she'd have this amazing denture. She was so sad because she spent all this money. And the reality is those teeth are set so far ahead that every time she bites down, they're not supported, and it's just a cant or a teeter-totter effect. So it pops the back off, pops the denture out of place. So all I did writing in the lab script is put, please place teeth over ridge. And that's all I put, and that's what we got. And it's fantastic results. So now when she bites down, the force is directed onto the ridge, onto the implants where it's supposed to be, and it's actually supported. So this is what you'll get. So again, there's a really good YouTube video, and that's all I watched to figure out how to add the copings. But there's a chair side acrylic, and then I ordered the copings through Strawman in this case. And so just had them added to the denture, did the process like I found on the video. So like I said, I can go into more in another lecture, but I just wasn't planning to be doing this. So but yeah, super easy. Same thing. One appointment, get all the records. Second appointment, deliver, add the copings, send them on their way. And the other thing also is that when you do this, or any denture adjustments, make sure you polish after. I've had a few patients come back where they've had a reaction to the acrylic, and it's not obvious at first. It wasn't for me. And then I was like, oh, I just forgot to polish it. So get a denture adjustment kit with some polishing cups, and make sure it's nice and smooth when you're all done. So that is all for today. The next one, we're going to talk about patient screening. So I talked a fair bit about it today. We're going to talk more about it. I have some a consent form that I give patients. We have post-operative sheets we give patients. So I'll provide you guys all that at that lecture, and then we'll just talk more about patient screening and setting expectations. I can't wait for May 3rd because that's going to be my favorite one, immediate dentures, and then the relines after that. So yeah, thank you everybody for coming and signing on.
Oh, thank you very much, Dr. Bertsch. That was very informative. Really liked how you're able to say not just how to do it, but how it actually helps the offices. I think a really important step there is you speaking of a patient who's had previous exposure with a traditional denture and how they've just been amazed that it's only 2 appointments now and they get to come in. So it's not just saving chair time, it's really impressing that patient and distinguishing you from the people down the street. So it's a great way to bring it into the office and not just help you out with another revenue stream, but also help out word of mouth from other patients. So
okay, that reminds me, I had one little story as a patient. So there's one denturist in town and me, and the patient comes and she's like, yeah, the denturist told me you'd have to send my teeth away to have them relined, and anything would need to be sent away. And I was like, well, no, now I'm a full digital workflow. I was like, you'll never be without your teeth. And she's like, hey, perfect, that's all I need. And it was like, she came, heard his spiel, and it was like, you're full digital. It was like sold. It was the easiest thing. So yeah.
It's a great process, and I'm glad you're able to share some of the success that you're able to have, because it's something that once you get into it, I don't see any reason why anyone would ever get out or want to go back to the traditional form.
No, I've never looked back.
Right now we'll open it up for a question and answer, see if anyone does have we just have not a question but a fact for you, that it was an awesome lecture, and wanted to thank you for that one.
She's one of my best friends. She's my head girl.
Oh, nice. Any other questions out there from anyone? Okay, are you able to see these as they pop up?
Oh yeah. Small dots that you can still capture some tissue better. Oh, I've never heard of the small dots. Actually, yes, that's true. I've also used the indelible stick if there's an area that's difficult to capture, and I'll just use that indelible stick and kind of like paint the tissues a little bit, and then it helps capture it. So yeah. Do you factor in line tissue areas that require relief? How do you factor in I'm not too sure what they're asking.
So maybe Akib, if you could restate what you're saying, that the question was, how do you factor in loading the tissue, i.e. areas that require relief? Is there any? Maybe if you could expand on that, Akib, that would be great. And we could also move on to Dave's right now. How is the bite captured in an edentulous patient?
So that's the one, like if a patient's totally edentulous, never had a denture, I take a scan of all the soft tissues, like similar to that scan I showed with the immediate denture, and then I have the lab make wax rims. There's some software coming out that I am hoping to try that will eliminate that, but for right now, that's the only way I've been able to figure it out, is still doing the wax rims. So I do the wax rims, take the bite reg, and then send that to the lab with the scan teeth. But yeah, that's the non-digital steps. So the areas that require relief, I'm just thinking like PIP paste is the thing that I use to show anywhere and it's burnt out. So you paint it on and it's striped, and then when you place it in anywhere that's burnt through and you see the denture, that's an area that's going to rub the tissues and require the denture to be relieved there. So that's my interpretation of that question.
We have one from Dr. WMJ. Can I duplicate a tooth-borne cast RPDU easily? Would there be any tips?
I don't, like for cast partial dentures, I don't scan the denture like I would with a complete denture. I just scan the patient's mouth. So scanning, I should have had an example, but yeah, I just scanned the patient's mouth, not the partial denture. I only scan complete dentures. So.
Okay. We have another one from Mo. If your denture is rocking after fitting, are you doing a wash to address this and have the denture remade or relined?
Yeah, so I'll put it in and I'll do those border molding movements. And if I pull on somewhere, or I pull on the lip, say, and it dislodges the denture, then I'll adjust that area and I'll keep doing that till it stops. So sometimes the rocking can be the flanges are too extended. So if you've done that, say you've done the border molding and then the reline because you thought it needed it, and then you get the simplest denture and it's rocking or it's not sitting or popping off, I'll do that, place it, do the border molding, and if it's dislodging the denture, I adjust it until it's not. But if that still isn't solve it, then yeah, I do a wash impression.
Perfect. So we have another one. Do you have to remove AI when scanning the dentures outside the mouth with iTero?
Yes, so important. Yes. Pretty much anytime I do a denture scan in any capacity, partials, immediates, completes, I remove the AI, disable AI cleanup.
Perfect. All right. How do we address OVD adjustments issues during immediate denture fabrication?
Honestly, I don't really like, so that's where if a patient has enough teeth and a stable bite, that's the bite I go with, because the reality is when they heal, the gums are going to shrink and you're going to lose VDO anyways. So I don't get focused on it at the immediate, at the like the first delivery of the immediate denture. When we do the second denture, the 3 months, that's when I assess. And I've had patients come back where they're wearing their denture and you can't tell because they've shrunk so much that the denture, when it was delivered, they had a smile, they had teeth, but because they've had so much bone loss, perio, whatever, they come back and it's shrunk so much. So that's when I take pictures, I take a scan of the denture, and then in that time I would do a try-in, and then you can use, and same thing there, I just ask them with the pictures, they can see, you can't see the patient's teeth. So then I ask for 4 millimeters, whatever it may be, to increase. So yeah, as long as you have a stable bite with the first appointment at the immediates, I just go with that bite because you know it's going to change and shrink. And if you don't have a stable bite, again, that's when I'll get wax rims made. So I'll do the scan. Some patients, their teeth just mismatch and they don't have a stop. So that's when I'll get wax rims and then establish a vertical with those. So wax rims again, where I still bring those together.
Perfect. Well, it looks like that's the end of the questions we have right now. So I guess we can, oh, just another one came in. Do you use complete denture codes for these immediates?
Okay, oh, I forgot to say this, and thank you for asking. We in Saskatchewan have a different code for immediate dentures, so I use an immediate denture code. It's the same price as a complete denture, if I remember correctly, but what I've done is include the price of the, so it's 500, so we've upped our immediate denture prices by $550, and that includes the cost of the second simplest denture. So I explained to patients that they don't have to be without their teeth. They're gonna get a second denture for free. The price is all included. So our immediate dentures, it's a different code, same price, but we've upped our prices, which I would encourage everybody to do, because I used to charge separately for the reline. And then patients would be like, well, I paid for this denture and it's shitty. Why do I have to pay for another one? And it's like, well, no, I told you this, but patients just don't remember what you tell them. So include it all in the one price, tell them it's a one and done, and they're happy with that. So.
One more here. Can you go straight to a try-in versus going with a wax rim bite block, and with or without photographs?
Yeah. I'm going to be honest, I haven't done like a patient who hasn't had dentures in a long time, but yes, that would be an option. Go to a try-in, use that as your bite blocks. And I always like to include photographs because, like I said, I didn't, and I started a couple months ago, and the results are just, the dentures just fit the patient and fit their face. And I think it's just because the lab has a reference point. So I honestly encourage to always include photos for complete dentures. Partials less, but for completes, yeah.
Well, that sounds great. And I'll also do a quick plug here where to add those pictures, it's really easy using the Orem customer portal. If you're not currently using that, I encourage you to contact out to your local PDC, get them to go over it because it really helps with the communication to the lab. Looks like that might be everything that we have here. So thank you for everyone who joined. I'm going to put up in a few moments a few QR codes. The first one is going to be a quick survey. After you take that survey, you'll be able to receive your CE points in about a week or so for those. The second one is going to be a link to the Orem Academy website. On there, you'll be able to sign up for the continuing series of the webinars with Dr. Bertsch, and also lots of truly other great programs that we have. We're really committed to education, and we want to make things as easy as we possibly can for all of our partners and customers to reach the levels that they're looking to do. So if I can just ask you to, oh, looking good there.
I was just going to say, if people have things they want in particular to know about, because I have to create all these content for these webinars, to email me, reach out to Orem, or in that QR, I think you guys have a section there to put anything you're interested in. So reach out and I would be happier than hell to include whatever you're interested in for dentures.
Perfect. All right, can I just get you to unshare your screen so I can then pop up the...
Oh God, I don't know. Oh, stop sharing.
Oh, there we go. So I will share mine. Is that working here?
It's not sharing.
Is that showing up?
No.
No.
Not showing up there. Okay. Let's see if we get. All right, I'm not sure why it's not letting me share my screen here. Oh, there we go.
There you go.
So we have the QR code. I'll leave that up for a few minutes. This is the QR code for the quick survey. Like I said, once you fill that out in about a week or so, you will get your CE points to your email. And here's the one for the Orem website, for Orem Academy. Definitely go check out lots of great courses, lots of different series that we have going on to really enhance everything that you possibly can in your practice. All right, and I think that just about covers everything for round one of the webinar series. Thank you again, Chris, and thank you for everyone else who has joined. Been a great evening or afternoon, depending on what side of the continent you're on. We thank you again and look forward to seeing everyone next month.
Thank you.